Well, let's say, Dr. Goldstein, we'll just kind of dive straight in then, if that's okay.
Yeah, let's go.
Excellent, excellent. So, a little bit of background about yourself. You are a prominent Los Angeles-based physician specialized in cannabis and pediatric medicine, medical director of Canna Centers Wellness and Education. You've treated over 20,000 patients, including over 2,000 children with conditions including epilepsy, autism, and cancer. You were awarded the 2017 Healthcare Professional of the Year by Americans for Safe Access. You're also medical advisor to Weedmaps, chief medical advisor for Neurotech International, CEO and co-founder at Goldstein Wellness, which helps to integrate cannabis into medical practices. Is that right?
That's all correct.
Excellent. That's quite the bio. So to get us started then, how did you become active in cannabis?
In around 2007-ish, a friend of mine asked me about medical cannabis here in California. She was fighting cancer and was feeling terrible from the chemo. We had been friends for years, and at the time, I had left pediatric emergency medicine. I'd taken some time off, and I was, believe it or not, just like teaching science to kids. I had taken a break from the medical world after years and years of working crazy shifts in the pediatric ER. I was just burned out. And I also had a young son at home and wanted to spend more time with him. I wanted to be more present. And when she asked me about it, I remember about cannabis from college, but, kind of had not really thought about it. And I said, well, let me just look and see if there's something here for you. And I started reading about it. And that's when I learned about the endocannabinoid system, which hadn't been taught to me. Although at the time that I was in school, medical school was around the time they were just discovering the system. So of course it wasn't being taught, still not being taught, which is a terrible thing. But then I witnessed her improvements. And I thought I was looking for something different to do anyway. And I just felt the universe had said to me, here, open your eyes to this. You just witnessed somebody who was suffering, who is now able to kind of rein in that suffering. Even though she's still going through a terrible time, she's saying that her quality of life is better. So there was something there. And I just started to do a little more research, and I became very interested in it.
Quality of life, that's actually a really important statement when it comes to cannabis as a medicine, because it seems to be one of the things that's relatively primary when it comes to cannabis medicine. So did you feel, was there like teething pains when you tried to integrate into cannabis as a medicine initially?
Yes. There were, first of all, here I am, a pediatrician, telling kids not to take drugs and all of that. I was able to see very early on that there was a difference between, and I don't knock recreational use. Look, people use a lot of different substances. I think cannabis is one of the safest ones. And certainly we don't have the death toll that we have with alcohol and tobacco, right? And other substances. But I think the hardest thing initially was, I was worried a little bit about my reputation. So I just kind of did it on quietly, saw my patients, didn't talk about it a lot with others. But it's just interesting that in the beginning, I learned more from my patients than me teaching them. They taught me. This is how I take it. This is what it does for me. The clinical knowledge, I thank my patients for that. Because then when you go read the research, you can kind of then meld it together somewhat. But yeah, there were some teething pains in the beginning. Here in California, of course, we had a law. It allowed doctors to approve patients. They didn't want us telling patients doses, even though I thought that was inappropriate. We should be telling people dosing. But at the time, too, we didn't have products that were labeled properly anyway. So, it was a little bit Wild West, as they called it back then. I would say that after about 3 to 4 months, seeing patients on a regular basis, it was crystal clear to me that people were using this as medicine. These were people who have jobs, they have families, they have children to take care of, they have elderly parents to take care of, and they were coming in saying, I got off my opiate and I'm more present. I'm a better worker. I'm a better parent. I'm a better spouse because my pain is down. I'm not barking at everybody in the house. I'm sleeping at night. And in the beginning, it was a lot of patients. What I realized, they had different conditions, but their conditions led them to very similar symptoms: pain, anxiety, depression, appetite issues, sleep issues, all of the things that cannabis is really good at balancing out. It was clear to me literally within about 3 months that all of these patients were having this very similar experience, but in their unique way.
That kind of alludes to kind of like a deficiency, which could be like the endocannabinoid system deficiency, which could potentially be obviously a connecting element. Often when I'm talking about cannabis to people and you mention the endocannabinoid system, they tend to not believe me because I don't have a degree, quite honestly. So could you detail specifically what the endocannabinoid system is?
You're not the only one that gets questioned. I had a parent once say to me, "Oh, I thought that was all a hippie hoax." I said, "They've published a lot of papers on it. That would be a pretty good hoax." So basically, what the endocannabinoid system is this physiologic regulatory system that modulates your homeostasis, meaning when you have an illness, an infection, some type of physical insult like a head injury or, a car accident where you're injured, what happens is your body goes into survival mode and pumps out chemical messages to try to help you get back into balance. And those are your inner natural, what I call inner cannabis compounds. They're called endocannabinoids, and they are released when there is a trigger, when you need to be balanced. Now, of course, it doesn't have to be some big major thing. It can also just be some cellular messages that are a little bit off. The whole idea with the endocannabinoid system is putting brakes on sending too much message. So think about someone like my friend who was getting chemotherapy. It was creating a lot of nausea, vomiting, some nerve pain. What the endocannabinoid system is supposed to do when you have those symptoms is to kind of put the brakes on those messages. But those are very adaptive messages. I mean, ultimately, chemo is similar to poison, and your body goes into this kind of overdrive, sending all of these messages like, alert, alert, you're being poisoned. What the endocannabinoid system is supposed to do is help rein those messages in so you don't feel all of that pain. You don't feel all of that nausea. They're adaptive messages, but what is happening is when you take the compounds from the plant, it kind of augments that system and allows it to put the brakes on those over messages. Another example is like when I have patients who tell me that they have panic attacks and it'll come out of nowhere. They think they're dying. What they don't realize is their brain is sending this over anxious message, triggering these neurotransmitter alert, 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 even though, let's say, a bear isn't chasing you. Yes, you're supposed to be panicked if a bear is chasing you, but if you're just driving down the freeway, you shouldn't have that, right? That's a mismessage, a misfire. What your endocannabinoid system is supposed to be preventing that. But as you mentioned, the deficiency, somewhere along the line, that system is not fully doing its job. It's either being challenged or it's being lazy or it's genetic for whatever reason. And you take these compounds from the plant and they augment and really kind of replace your inner cannabis compounds to reestablish that homeostatic message to get you back into balance.
It's perfect because often when I'm talking to people about these kind of things, I try and emphasize as well about the notion that is, and correct me if I'm wrong, that the endocannabinoid system is essentially top of the physiological system hierarchy. Is that right?
Yes, I believe so. It's one of the most widespread receptor systems in our brain and in our body. It controls our thought process, our emotional being, our ability to be resilient to stress, our ability to control our inflammation, to regulate our immune system, to regulate our gut. When I think about the human body, I think about what are the main important systems for wellness: brain, immune, gut. And the endocannabinoid system is elsewhere, almost everywhere, really. But those three major organ systems, which we kind of divide up, right? So if you brain issues, you see a neurologist or psychiatrist. If you have gut issues, you see a gut specialist. If you have immune problem, you might see whichever specialist is how it's expressing itself. But the reality is that when you have over messaging in the brain and over messaging of the immune system, over messaging in the gut, you're not well. You don't feel good. And we all know the gut and the brain are very connected now. Of course, we didn't know that way back when, but now we know that the endocannabinoid system is essential to a normal functioning brain, to a healthy gut, to a healthy immune system. And there's so many things that can go wrong. I mean, again, there's genetic causes, there's acquired causes. Acquired might include a tragic accident or a something that you're eating that triggers inflammation or chemicals in your environment that are messing with your immune system. There's so many things that could tip our endocannabinoid system to be off, but then we have this plant that kind of comes, and I hate to say it, but it kind of rescues us. And one thing I want to say, and I wanted to say this earlier, I don't feel like I'm curing a lot of people here and there. I cure people where people say, you know what, I don't really have my issue anymore. My endocannabinoid system's in balance. I'm good. But in general, what we're doing is we're just interfacing with that system and feeding it, taking care of it, and allowing it to do its job, which then leads off into wellness.
So that can imply then that the phytochemicals present in cannabis can also be described as almost like nutrients, micronutrients.
Oh, phytonutrients, absolutely.
That's one of the things I think is quite fascinating. It makes it challenging to navigate the world of cannabis because it's so diverse. So you have this nutritional element when it comes to the plant feeding the endocannabinoid system. You have this recreational element when it comes to obviously people that want to kind of interact with their sense of sensations and consciousness. Then you have the medical side where people require it medically, you know, for a specific issue. And on that note, like the medical issue, when you have somebody that shows up to your practice, the endocannabinoid system is so subjective. How would you orientate dosing?
Right. So the practice of medicine is, I mean, there's a bit of an art to it, I suppose. Over the years, you learn and you do, and you put your 10,000 hours in, and you get a sense, especially when you're talking to a lot of people. And this is why doctors go through so much training, 4 years of medical school and then their internship, their residency, and some training programs are very long in order to really understand how to do this the right way. So I think when I'm speaking to people, what I'm looking for is to see, is there an endocannabinoid system issue, right? A dysfunctional issue. That's the whole point of spending time with someone, to understand what their medical issues are. But more than that, what is it they're looking for with cannabis? What do they want to treat? And ultimately, what does wellness look like for them? For some people, it's just being able to get out of bed without pain. And for other people, it's being able to run the 5K without, migraines interfering with training or whatever it is. So what I do is I just gather up the information. I look at who this person is, what are their symptoms that are interfering with their quality of life. And then what I do is, and what's interesting about cannabis medicine is you treat more the person than you do the condition. Because as I mentioned, lots of conditions have similar symptoms. I might not be able to cure a child of, let's say, a autoimmune condition. Again, cure is such a funny thing, but how about helping them manage, right? And that's really what we're doing with pharmaceuticals too. When somebody has a condition like that, you're just managing the symptoms. So what I do is I ask people, what are your goals? Your top 3 goals. So for instance, I just met with a family this week and they were telling me their goals for their child is better focus, not running away, eloping, which is a big problem with this particular child. And I think for the mom, it was like the hyperactivity and the repetitive behavior. And the dad had a different list, but they were similar. And so I say, okay, we're going to try to tackle these issues. And then we'll see what that first cannabinoid. So for that particular patient, I started with a high CBD, low THC. Let's say that family said to me, our child's highly aggressive and is biting and kicking people and throwing things at people's heads. Then we might go more towards a balanced CBD THC to try to calm down that aggressive behavior. If someone has a sleep issue, I lean towards a little more THC and maybe during the day, something different. So it's really individual. There is no one size fits all, as you know. It's trial and error, unfortunately, still. But in general, I've become kind of good at determining when somebody, if a parent or a patient gives me feedback, and again, because I've seen so many patients, oh, this is a low dose person, it becomes pretty clear. It's really just that back and forth with that feedback. If somebody can give me good quality feedback, we can usually figure out. Dosing is always start low and go slow, always, even with CBD. And part of that is, one, if you start at very high dose right out of the gate, your people are going to be a bit turned off. Their body you have to accommodate to this. I had a mom, I'll just tell you a funny story. She told me she wanted to know what her child was feeling when they took a certain CBD dominant oil. And she calculated that her child, who was small, she was 5 times the child's weight. So she took 5 times his dose right out of the gate. She drove to go. I know you're laughing because you know what's going to happen. Drove off to the store, wherever she was going, and she called our office and she said, "I can't get out of my car. I feel really bad." And I said, "Well, so tell me." So she told me what happened. I said, "Okay, so in that oil, it's like a 25-to-1 ratio of CBD to THC, but you are THC naive, and all that THC all at once, 5 times the dose that your child is taking." I think it only ended up being about 7 milligrams of THC, but she was cannabis naive, and the CBD is not gonna prevent somebody who truly is cannabis naive from not feeling that THC. I mean, a very expensive way to get high. I wouldn't suggest anybody get a high CBD, low THC to get a THC effect. Just take THC, but we reassured her. Her husband or a friend came and picked her up. She left her car, came back for it later, but she was fine. This is why we start low and titrate up. Everybody has what I call their ceiling for THC. But for the other cannabinoids, the whole goal is, and for THC too, minimum effective dosing. We do not want to start at some dose. Let's say even if it works great, especially too, it's out of pocket cost. What if half that dose worked for you? So that's why we start low, titrate up, is to really dial in for each particular person that gives them the best result without side effects. And that's what we call the minimal effective dose.
What pops to mind when you're talking about this is the notion of randomized controlled trials and what they're looking to do with the targeted medicine and how cannabis completely contradicts that format. I mean, what kind of influence do you think that has still to this day?
Everybody wants a standardized dose, and there is none because your endocannabinoid system is coded by your genetics and it is also responsive to your lifestyle. What dose are we going to give people? So, for instance, for CBD, I have children that take 1 milligram per kilo per day. We usually do weight based in children. And I have others that take 20 milligram per kilo per day for the same exact indication. I understand the concept of standardized dosing, and that works fine for pharmaceuticals, not always. But at the same time, I agree with you. Randomized controlled trials can be very interesting. But in order to have a successful randomized controlled trial, you have to have flexibility in dosing with the ability for patients to titrate up, titrate down, and potentially even have access or have as part of your study drugs different combinations. There was a study that came out of Israel in 2019 that used a 20-to-1 ratio of CBD to THC in children with autism. And in the children that didn't respond well, they added in or they gave them lower CBD THC ratios. And they found that about 50% of kids responded to the 20-to-1 with good results, what either, improved or very much improved. And then another 30% of the patients that didn't respond, 30% of the other 50%, did well with added THC. And that just goes to show you it's not one size fits all. They all have the same condition. But remember, too, it's a spectrum condition. And we really should think about all conditions are spectrum conditions, really, right? So this personalized, customized approach is absolutely necessary. It is clinician labor intensive. It is patient labor intensive because you got to take good notes, keep track. You have to be willing to try different products. Sometimes they get it right out of the gate, and sometimes it's the 5th product we try or the 8th product we try, and it's 6 months in and we're still trying to dial it in. But when you see some improvement, then the idea again is to take all of these cannabinoids and all of these different products and kind of narrow it down to that person, the best regimen that you can come up with. And so the way I do it is I usually start with a monodominant, although sometimes I use like a 1-to-1, which is, a balanced half and half CBD THC, but usually a monodominant, either CBD dominant, CBG dominant, whatever I feel is appropriate. And I explain to the parents, we're going to rule it in or rule it out. It's either going to work or it's not going to work, or there's going to be a mediocre response that we can do better with. But the whole idea is to start low, titrate up, give me feedback. Let's say we find great results. That's great. We figure out what dose, the product, and then what I'll say is there room for improvement? And if the answer is yes, Then we go to the next logical cannabinoid. Is it going to be THC? Is it going to be CBG, CBDA? And then we layer it on. We have a baseline understanding of what this particular product is doing for that patient. And then we layer on. With many of my patients, the parents have a list of all the different cannabinoids. I talk about the kids a lot just because that's really what I'm focused on now, even though I still have a lot of adult patients in my practice that continue to come to see me despite legalization. They just want to be educated. They want to be involved with the doctor with this. They want to know that if they get a new drug, they can call somebody who will tell them whether or not there's a drug interaction. So that's why people stay with me. But for the pediatric patients, it's a matter of layering it. And you may be familiar, I published some research a few years ago working with a company called Canformatics. We were measuring salivary biomarkers in children with autism before and after they took their cannabis medicine to see how did their metabolic pathways change. Okay. What's interesting is that if you look in the paper, we have a chart of the patients, anonymized, of course, but we show their medical cannabis regimen. And not one child, there's 15, it's a small study, it was proof of concept, 15 kids, all with the same condition, all taking different cannabinoid regimens, different doses. And it's just important, how did we get there, right? How did you know that this regimen would work for that child? It's a lot of labor behind that, a lot of work. Parents doing it mostly, but again, giving me feedback and me kind of pointing them, helping guide them through this like labyrinth of all these different products.
Yeah, so you're kind of touching on the personalized medicine there then with that, and it just seems like a massive challenge with the complexity of the endocannabinoid system. And then, like, for anybody that's unaware, cannabis has 500 plus molecules. Never mind the cannabinoids. You're dealing with this. It's like a phytochemical factory, and you're trying to match it with this ever-evolving physiological system. So, I mean, is there a mode of having an endocannabinoid system template, like a test that can be done and stuff like that can give a bit more insight?
So it turns out that like drawing blood and looking at levels in the bloodstream of either CBD, THC, and so on isn't really all that accurate in terms of that. It doesn't correlate with response. So there are people who have low levels of CBD in their bloodstream who have a great response, and other people have high levels and they didn't respond. So it appears it's more about metabolism, and it doesn't appear to be necessarily related to a therapeutic range like you might have with a drug where they, like a seizure medication that has a range of therapeutic range, or with some blood thinners have a therapeutic range. There's a slew of medicines where we check blood levels. It doesn't appear that cannabinoids have that correlation. The salivary biomarkers, we're not looking at levels of CBD and THC. What we're looking at is how those compounds affect the pathways.
Sorry to interrupt, Dr. Goldstein. I was going to ask, so when you're measuring CBD and THC, are you measuring it in the form of anandamide and 2-arachidonoglycerol? Is that how you're measuring them?
So no, you can actually measure THC levels in the blood. You can also measure endocannabinoid levels. So there was a study in 2018 from Stanford University here in California that took a group of children with autism and a group of neurotypical children, and they measured levels of anandamide in the bloodstream. We think that, remember, what's happening with anandamide and 2-AG a lot, is in the brain. And so you can't go in, I'm not allowed to go mucking around in your brain. You can do a spinal tap and collect fluid from the cerebral spinal fluid and measure. And they have done that in studies. There's a study with schizophrenics where they have first-time presentation schizophrenics, and they've looked at levels of endocannabinoids in the spinal fluid. It's just a very invasive procedure that you wouldn't want to subject people to measure their levels, right? And so we were able to use the saliva to measure the levels, and we were able to also measure what cannabis treatment was doing to levels. So for instance, in some children, there's one particular compound we measured called N-acetyl aspartate. It's the second most abundant brain chemical. It's involved, of course, highly involved in neuronal function and so on. And in our patient population of children between the ages of 6 and 12 that were on established dosing of medical cannabis, what we found was before they took their medical cannabis, some of them had basically almost non-existent N-acetyl aspartate, and some had sky high. What was interesting was the older kids closer to puberty had very high levels. And when we measured the levels about an hour and a half to 2 hours after they took their medical cannabis, we had this physiologic range that kind of what you would call the where you would expect these levels to be if there was no concern of a dysfunctional or dysregulated brain function. So we had those levels, like basically what you'd call the therapeutic range or the physiologic range established by children who did not have autism. And the kids with autism were well below or very high. And what was interesting was after their cannabis, their levels migrated towards or shifted towards that physiologic. And that correlated with what the parents were reporting in the behavioral surveys that we were doing before and after. So we had 11 kids in the morning, and these are kids who are, being treated. They would wake up in the morning. They didn't have their cannabis for at least 8 hours. And so the parents did these behavior surveys. 11 out of the 15 kids had severe symptoms in the morning. And by 1.5 to 2 hours later, after the cannabis kicked in, we had 11 kids that their behaviors were significantly improved. And it's never going to be perfect. And asking a child to collect saliva in a tube and they don't want to may have stressed them out. And that's why their behaviors were a little bit difficult. But what's interesting about it is it's the beginnings of understanding, basically mapping that individual's baseline chemistry and then what does cannabis do for them. And then we were able to take our data and we had a machine learning evaluation. And what we showed was that CBD had certain pathways that it affected, THC had certain pathways that affected. Interesting, the pathways didn't overlap for THC and CBD. So for those people who say no THC, so do we leave those pathways, off, dysregulated? CBD is not going to do that. It doesn't have the same targets as THC. And then really interesting, CBG had many pathways that it affected, and it overlapped with each CBD and THC some pathways. So this is the beginning of understanding if we can map somebody's baseline chemistry, physiology, these biomarkers, and then start them on treatment and then reevaluate. It's kind of like giving somebody a cholesterol medicine. You're 250 before and now you're 200. It came down. Okay, the medicine's working. But this is a little more like when you say there's so many things in that plant that you're taking. Now we can try to break it down and see which compound is affecting which pathway. I really feel that we're on the cusp of some breakthrough here so that I can have you spit into a tube. We can evaluate where you're at. Is cannabis even going to help you? Or all your biomarkers kind of falling in the optimal range? Maybe cannabis isn't the answer, right? Because there's nothing to treat. And then there's some of the kids we mapped had many of their biomarkers well beyond the standard, 4 standard deviations away from the mean. And we know that in the patients we saw that it was corrected. So, we're doing more research now. The company's doing some research for migraines, which is really helpful. And then they're also focused on some other conditions. So other conditions like dementia, endometriosis, all these conditions for which we just don't have great treatments. And we know that the endocannabinoid system is involved.
I love the fact that it's like the CBG has a crossover for both pathways, and CBG being the precursor, metabolic precursor in the cannabinoid family line when cannabis is being cultivated, which is kind of implied a synergy physiologically between us and the plant in that way slightly, which I quite like.
It is really interesting because other research groups have hypothesized or found that CBG, and this is the terminology we used in our paper, CBG resides pharmacologically between THC and CBD. So it has overlap with both, but not impairing, but also you don't need these, often high doses that one needs with CBD. And it seems to, if you talk to people who are using CBG, and we don't have a lot of we have I think one clinical trial on CBG in humans looking at anxiety, and yes, it did pan out to be statistically significant. But when you ask people what they're using CBG for, pain, inflammation, mood, including anxiety, depression, and then some people say sleep, and it's kind of like CBD for sleep. It's not a hypnotic where it kind of knocks you out, but what it does is it helps calm your anxiety, it helps calm your inflammation, likely helps reduce any type of discomfort that you might be having from pain or inflammation, which then allows you to fall asleep. When we have less anxiety and pain, we sleep better. When you climb into bed And all of a sudden now you're worried about what happened all day. You're worried about what tomorrow brings. And oh, by the way, your back hurts because you're finally not busy taking care of everybody else around you or working. All of this stuff rushes in at night when you lay down and then you can't sleep. We're finding that, for my purposes or in my experience, THC and sometimes CBN very helpful for sleep. For some people, CBD helps sleep. And if somebody tells me that CBD gives them that, I don't argue with that. But if someone comes to me and says my number one on my list of things to fix is my sleep, I don't go to CBD first.
That's interesting. What would your first be THC for sleep issues?
Yeah, an appropriate dose of THC if they're having inflammation or anxiety is part of it. Some people they just maybe have habits that too much caffeine or and we talk about all that, all the sleep hygiene things that we talk about, what can you do better? What else can assist? You don't wanna keep a bad habit and then try to correct it with cannabis. It's better if you maybe get rid of the bad habit and have cannabis help you, assist you in that. But yeah, I find, for a lot of my patients, they do well with low dose THC at night. Some people need a little bit higher dose. Again, I don't judge the number, it's what that person needs. I have some pediatric autism patients that don't sleep. They have terrible circadian rhythm dysregulation. They have a ton of anxiety. And I find that some of them take very high doses of THC at night just in order to fall asleep and then have a very nice day the next day. The family's well rested, the child is well rested. It just makes for a better quality of life for everybody. But I don't judge the number as long as it's effective. And this is one of the keys is that THC is one of the only compounds that causes tolerance. And what happens is, we were talking about the receptors earlier, right? Cannabinoid receptors is part of the endocannabinoid system. Tolerance is like a self preservation mechanism. If you hit the receptor over and over and over, inundate it with THC, the receptor migrates inside the cell and hides. And so you have to overcome that by taking more THC. That's why your dose escalates. The beauty of the endocannabinoid system is if you, let's say, stop using THC or lower the dose significantly, those receptors kind of get an all clear signal and they'll pop back out to be on the surface of the cell again where they can then interact. Remember, those receptors are not there for THC. They are there for your inner cannabis compounds. So when you use THC and you alter that, now your inner endocannabinoid compounds have lost their target. And what ends up happening is you lose some of the medicinal benefit. And you may notice, because I hear it all the time with people who overuse THC, who come to me and say, can you help me figure this out? It used to work and now it doesn't. It's simple, right? You're not having a balanced regimen. You need a balanced regimen in order to keep those receptors interacting. Now, that's not to say everybody gets that. I have patients who have been on the same 5 milligrams of THC once or twice a day or just at night for years, even, 10 milligrams, let's say. But as patients will tell me, oh, I see my dose is escalating, that is a sign of tolerance. And if you can, the first thing to do is to just take a break. We call it a tolerance break. Some people call it a THC holiday. Whatever you want to call it, it's just taking a little time off. And the research tells us that those receptors reestablish within 48 hours. Now, I often tell people to take a few more days just to kind of ensure that, because that's, of course, based on one study. That might not be everybody. But most people who take these tolerance breaks, then what they're able to do when they restart their THC is use a much lower dose because now they have their receptor sensitivity is back. And the words we use for the receptor movement, so receptors downregulate when they hide inside the cell and they upregulate when they come back out. What we have found is CBD appears to help mitigate some of the tolerance. So I always like a balanced regimen if someone is using THC. But again, I have a lot of adult patients who only use THC. They're using it mostly at night, end of day, right? Relaxation, pain relief, anxiety relief, sleep. And it's a beautiful medicine for that. But if a tolerance starts and you are losing the medicinal effect, that's why. is you've downregulated your receptors, but it's a dynamic system and it responds to either abstinence or lower dose or having some other cannabinoids in there. So I don't really find it a problem. And you have to remember too, though, Connor, is I'm working with patients who have medical issues. And, one of our pioneers here in California was Dr. Todd McArea. He was one of the first brave doctors to start recommending cannabis, despite the fact that the medical board and law enforcement were threatening. He has this famous saying, which all use is medical use.
Legend.
And I believe that to some extent, right? I believe that to some extent, and especially before legalization, because really think about it, who's pursuing cannabis if you have something to lose and go to jail and, have legal issues? You're pursuing it because you like the way it makes you feel. It's probably helping you on some level. You may not necessarily dial in on that, but you just feel better on it. Of course, we know that there's a small percentage of people that become dependent on it and are overusing it. But in the medical field or in the medical side of things, I just don't see a lot of issues. And yesterday, I kind of was arguing with people on social media, trying to show them I've been doing this a really long time. There is, of course, problematic use, but it's not the majority of people using cannabis do not have problematic use. They're using it responsibly, the same way people use alcohol, or the same way that, someone might get a prescription for opioids from their doctor. I'm only taking them when I have to. I don't, just because I have them doesn't mean I'm going to take them or abuse them. And so I think we have to start treating people like adults and try to just educate. That's the key, is education. Understand what you're getting yourself into, so to speak, with any substance.
It's fascinating, actually, because obviously I've been like a recreational cannabis consumer since I was about 13 or 14, which is obviously way too young, inevitably. But even in that period of time, I've went through fluctuations of obviously excessive use and then abstinence and all these kind of things. Like last year, I made a kind of resolution with myself. I think it was the beginning of April, and there was no consumption whatsoever until the end of October. It was something along the lines of that. And I was working on a film and other projects and stuff. And one of the things I've noticed that over the years, the quantity in which I was consuming prior to the tolerance break was significant to tell me how I felt when I was taking the break. So if I was consuming high levels of THC, high amounts of cannabis, the coming off the first couple of days was always like appetite was kind of messed up, sleep wasn't that great. Whereas if you just kind of metered it down, if I'm being honest, I'm in the process of creating a book called Getting Out of the Weeds. And it's for people they find it challenging to stop consuming cannabis, because we're in like a little pocket of like a medical revolution. So inevitably you're going to be speaking positively because it's a medical revolution in a positive sense. And then you have also legalization, where there are regions around the world, obviously the States being one of them, where it's becoming much more readily available. So for people that are sensitive to it, it becomes challenging to echo that it's negatively impacting their life. And on that note, I think one of the interesting things for people that are unaware of cannabis is that when they're talking about THC, these things are biphasic. And the differences in doses will determine the feeling that you get, the experience you get from it. Is that something you came across with people that are new to cannabis?
I'm not sure I understand the question.
But the question being, when people are approaching you to talk about cannabis initially, and then they'll be talking about like anxiety with small amounts of THC, but if they have large amounts, they won't have any anxiety. They might be questioning why that's the case.
So the biphasic nature, of course, is very interesting, right? I mean, so THC can actually cause all the things it can relieve. It's just different ends of the dosing, right? And there's the saying, the dose makes the poison. And so I explain it all when I'm meeting with a patient. That's why it's a long first visit. It's mostly to collect data from them, but it's also then to educate. And this is also why I wrote my book, Cannabis is Medicine. It is to educate, biphasic, start low, go slow, like all the basic ideas of everything that we've been talking about here. And I find it really interesting. This is not proprietary information. This is information we should be sharing. Just telling kids don't do drugs, that's not, I mean, that almost is like saying oh, don't do it. Well, I think I do want to do it, right? But when I think about when somebody tells me that they might have problematic use, or let's say, what you're describing is that after high levels going off, like doing a tolerance break, what you're describing is withdrawal. And the withdrawal it's not anything major. It's your receptors, your endocannabinoid system is dialed down. You have down regulated a system that you need to make you feel better, right? You didn't do it on purpose. It's just the physiology of it, right? By inundating those receptors, they downregulate and hide. Then you stop. They don't pop out right away. They need some time. And during that time, as your cannabinoid receptors are reestablishing their availability, you don't feel great. And you think about the side effects that you had: brain, gut, inflammation, right? So for some people, the withdrawal can be very overwhelming. So there is a paper from 2013. The researchers somehow met a young woman, 19 years old. She started smoking cannabis, THC, when she was 13. Heavy use over 6 years. Every single attempt at discontinuing her use resulted in severe anxiety and a relapse back to use. And so it's an interesting case report in that they asked her to go into the hospital and they said, we're going to give you high dose CBD and we're going to measure 4 different measurements of like withdrawal and anxiety and depression on these validated scales to determine, does CBD help with, will it help you get through this withdrawal? And what's interesting, so the first day they gave her 300 milligrams, which again, I had just said, don't start high dose, but in someone who's using a lot of THC, they can handle the CBD. That's like a cupcake compared to, anything else. Then they doubled up on the dosing from days like 2 through 10, I think. So that 300 milligrams twice a day. And then they gave 300 milligrams on the very last day, day 11. And if you look at the scores of the various ratings, so when they ask her, rate your anxiety, 10 out of 10, rate your depression, 10 out of 10, rate your withdrawal symptoms, 10 out of 10, whatever it was. And I'm just making those numbers up, but it's right there in the paper. By about day 5 or 6, she was completely fine. Her anxiety was well controlled. Her overall withdrawal symptoms were significantly decreased. That was in 2013. We have nothing else showing us that, but I've always remembered that paper. And I've had some patients who are high-dose THC users who call me and say, doc, I've got knee replacement surgery coming up. What do I do with my cannabis? Right? Because they're going to be getting surgery, anesthesia. Then they're going to go home with some opioids. What do I do with my cannabis? And so what I tell them is, well, first of all, depending on how much, and they'll relate to me how much they're using, if I suspect they're going to have withdrawal, who wants that at the same time that you're having surgery? I mean, that's just compounding misery on top of misery. So to me, it's let's back off on your THC. So we're going to they'll share with me their use pattern. I'll show them how to wean it over that week or 2. Hopefully, we have a little more time, and we'll add in some CBD to help give them a buffer. And then they can stop using their cannabis for their surgery and then reintroduce it a couple days later to try to help with pain, sleep, all of the things that you need after surgery, help with healing. And then I usually try to convince them to, if the CBD was helpful, to keep a little bit in there so that they are just kind of, feeding their endocannabinoid system in a more balanced way.
We talked about it a little bit earlier there about children with autism and how cannabis can help that situation. Could you talk a bit more about that in detail? Unfortunately, in the UK, we have obviously a medical framework which is very restrictive. So we really struggle to kind of get access to the very, very few medical cannabis products we have. But for people that have access to things like CBD, I mean, the CBD, as long as it was a legitimate product, that would be helpful for somebody that has a child with autism?
Well, it depends. So, when we talk about CBD, it can be confusing because there's so many things with CBD. So there's products that have CBD, have THC. That's still a CBD product. It's a more balanced ratio. Then we have CBD dominant. I usually like to call them, to call out that, remember, it's high CBD, but there are other cannabinoids in there, including THC. And just depending on what product you get, it could be a hemp versus what we here call cannabis. So based on that 0.3% THC by weight. But when we're talking about CBD in general, so we have a body of studies. The majority have documented a 20-to-1 ratio of CBD to THC can help children with autism. It's not across the board. As I mentioned earlier, some of them need more THC. There's a study with a 33-to-1 ratio that was successful. There was a study, 75-to-1 ratio, that kind of, in my opinion, published their outcomes in a little bit different way to maybe show benefit, but I haven't found across the board that much higher ratios Like my ratio range for my patients is 20 to 1 to 30 to 1, somewhere in there. And then if they have aggression, severe insomnia, self-injury, elopement, or a lot of really challenging symptoms that are almost safety related, then we'll use that 1 to 1. And why is that? Well, as I mentioned, there was a study here in California that showed that children with autism have lower levels of anandamide compared to children who don't have autism. So that is a true deficiency. We learned from our esteemed father of medical cannabis, Dr. Meshulam, that THC and anandamide mimic each other. Those are the two that mimic. So if you give CBD and someone is having major issues from limited anandamide signaling, CBD may not do the trick, right? And so some THC in there can help. So CBD, in my experience, and based on these studies, by the way, is one other study that did a 9 to 1 ratio. So we do have a study that has that lower. And then that original study that I told you about where they added in the THC, they went as low as the 6 to 1 ratio, and then kids that were non-responders to the 20 to 1. So we have this slew of ratios. And overall, what we're seeing is like 70, 80% response rate. But what's the response? So less hyper, maybe less aggressive, better communication, better focus, and some better speech. Sleep is better, less rage attacks. In those kids that have autism and epilepsy, we often will see less seizures. There's a whole slew of responses, right? Less sensory issues. Oh, one big one is less rigidity, right? So kids with autism or people with autism sometimes are on a preferred task or a preferred activity, and they don't want to leave that. And that's difficult when you're in school and they're trying to shuffle you through the school day. So we see a lot of those benefits, but I'll tell you, even I am been doing this for a long time. I'm not afraid to use THC. I, of course, give specific dosing. Again, lowest possible dose. If a parent calls me and said, my child is glazed over, doctor, I say, okay, what dose, what product, and we change it. And so I just got feedback this past week on a patient where the mom said the child just seems a little disengaged, a little bit in his own world. Glassy eyes? No. Also, a little more interested in food than we normally see. That's telling you it's not hard, right? And what we did was we went, so at the dose that the child was at, we just went down a little bit. And then I get an email, we had the best day ever. So it's a matter of dialing in. Because a child got a little loopy one day, or for 3 hours or 4 hours or whatever it was, does not scare me, because we're not going to leave the child there. That's not the goal. And in fact, the goal of treatment is to not be impaired. The goal of treatment is to just mitigate some of the symptoms that are making life challenging for the child and for the school and for the parents and for the family. And it doesn't always work, but I think 70 to 80% response rate is actually pretty good. And that's what we also see with epilepsy. I would say that's what we often see with chronic pain. So I've got kids that don't take any CBD. They'll just take, let's say, CBG and CBDA. That's what their body responds to. So again, going back to my motto, rule it in or rule it out. If CBD is not working and we've tried 2 or 3 different ratios or 2 or 3 different products, I just get rid of it and we go on to the next thing. CBG is usually next, or CBDA is usually next. There's a small study from a company in Australia that looked at a CBDA dominant botanical formulation for epilepsy, or sorry, for autism. And I just disclaimer, I've been doing some consulting work with them, but they got a very nice response rate. Around 93% of the patients responded. Now, why would CBDA work? So CBDA is cannabidiolic acid. It is the raw form of CBD. It's in the raw plant, so you're not heating up the plant, right, to make the product. It's a very potent anti-inflammatory. And when you look at children with autism, they have, and it's well documented, increased neuroinflammation and gut inflammation compared to the general population. So why wouldn't we target inflammation?
But I find this fascinating, Dr. Goldstein, because it's specifically when you mentioned there when the child's got the glassy eyed because the dose is too high. Relatively speaking, that's nothing compared to 2 McDonald's and a tin of energy juice, and I think that's what, like, there's that thing where in society.
Or antipsychotics that get prescribed that cause metabolic syndrome, hypertension, obesity, gynecomastia in boys, making a boy get a breast reduction. I mean, my goodness, so This is one thing that we know with cannabis is we just don't see irreversible side effects. They're all reversible with cessation, discontinuation, or changing the dose. I tell everybody any side effects you get from a cannabis medicine regimen, those side effects can be mitigated by changing dose, product, timing, or discontinuation. And because we now have so many products available, so CBD, dominant, CBG, CBGA, CBDA, CBN, THC, THCV, CBDV, we have so many now, and it can take time. And that's why I tell people it's kind of tedious to rule it in or rule it out because you got to start low with each one, titrate up, see what the benefits are. You might have to switch to a different product if maybe the terpene profile isn't right, but it's doable. It's a journey. It's not here, call me in 3 months. That's just not the way to do cannabis medicine. Like I said, it's a little bit labor intensive, but usually with this high rate of response, we're seeing benefits already. When a parent calls me and says, we had a good week, it's not perfect, but we had a better week, we're on to something, right? We're moving towards that. I even had one parent, this is a young man I saw many, many years ago in my practice. He has a genetic syndrome, and he came to me in a wheelchair. I think at the time, now he's like a young adult, like he's 20 or something. When he came to me, maybe he was like 9 or 10. So I've had these very long relationships with many of my pediatric families. So I get to witness that. And when people say to me, what about long-term studies? Okay, we don't have them. We've only just started really. I mean, we know long-term in general, cannabis is very safe. It's been used for thousands of years. But like in a pediatric, changing, developing, growing population, what do we see? If they're responders, it just doesn't seem like we see issues when they're on a medically supervised, properly dosed, clean medicine regimen, right? So there, you have to fulfill certain criteria. This young man came in, he had seizures, persistent vomiting, and self-injurious behavior, and then the occasional aggression. And within the first couple of months, which the parents didn't even expect improvement in the vomiting. I don't know if you guys have over there those like red cups that people have at parties. The parents would travel with those. They were actually on the child at the bottom of his wheelchair in like this little basket that had all of his medical equipment, let's say. And they would travel with it because if he started to get nauseated, they would just take the cup, he'd puke in the cup, and then they could throw it away. The mom's like, I'm stopped with the towels and I've stopped with this. I realized what she said, she thought she needed the, airline, the bags on the airlines, right? The sick bags. She had cups. And within months, she said, no cups. We're not traveling with cups anymore. So it was very meaningful for her. But this child virtually stopped having seizures. His self-injurious behavior significantly decreased. So no more vomiting and everything else is better. And then she sends me a video of him getting up and off the wheelchair and walking around. I have this video. I'll never forget it. He walked from the living room down the hall into the bathroom. He wanted to look at himself in the mirror. And this is a fairly disabled child. And one of the things she said to me, which I'll never forget, a few years ago, she said, it just keeps getting better. Now, that's so interesting, right? Because people are worried about long-term brain development effects. And here you have this child that really had not such a great quality of life, who's now exceeding anything that we imagined.
That's phenomenal.
It is. And he's just one story. When I talk to new families, or if I'm talking like to you, we don't know what the child's potential is. Certainly, we want to give them every chance to reach the best potential, their best quality of life. Fighting the propaganda over the last, 80, 90 years, I'm tired of it. It's all out here in front of you. If you bother to talk to anybody, talk to these families. Don't talk to me, talk to them and let them tell you. They're the ones paying for it out of pocket. They're the ones giving it to their children and witnessing these benefits. It's not just me saying it, right?
Yeah, no, I feel the same. There's lots of people watching this that will feel fatigued over this last century, and I think that's also, it shows where like the absence of that, like even though it's an exciting time, the absence of research until this point is, I think, what gives us this difficulty in translating these positive results to the scientific community that are kind of hardcore. And it was actually one of the things, I've got kind of two questions on that. What is it like where you're working now in Los Angeles, fluency wise, with the already established medical establishment in the format there, and then this newly emerged, probably privatized clinic format when it comes to medical cannabis. Is there a synergy? Is there a crossover? What is it like?
A big sigh because it's really challenging. The medical community has been very slow to adopt this, and it's because they want the randomized clinical trials as the gold standard. And as you know, cannabis doesn't fit that model. So what we're seeing is like just recently, which was infuriating, there was an article that came out in a prominent newspaper that said there's no evidence that cannabis really works for X, Y, and Z. And I'm like, so you're just basically telling people, I don't know, it's all in their head or they don't know how they feel, which I find is incredibly egregious to tell people that. People know how they feel. We can treat people like adults and trust them when they tell us they don't feel well or if they feel better with something. What's interesting is that they're going based on the totality of the research, but they never comment that the research has been prohibited. And the reason that we don't have 1,500 studies that show that cannabis can help with whatever condition conclusively is because, if it's not in the scientific literature, the medical community doesn't want to accept it. And what they'll say is, oh, that one study is not meaningful, or, we need more than that. It's a problem. Cannabis does not fit the pharmaceutical model, but it shouldn't have to. It certainly shouldn't have to meet this double standard, which I think is, I'm sure you might agree with this. It seems to me that cannabis has to work for every single person and be 100% perfectly safe for every single person before anybody will accept it. And we certainly do not have that criteria for the pharmaceuticals that are being offered to people. I mean, even when my son was younger, one time the TV's on, he's on the floor playing with his little cars, and he looks up because he hears the commercial with the pharmaceutical saying may cause diarrhea, and he thinks that's the funniest thing in the world. He's a 7-year-old boy or however old he was. And he's, who would take a medicine that makes them have diarrhea, Mom? Like out of the mouths of babes. Okay, I understand with serious condition and the medication may be indicated, but we've been trained to accept unwanted side effects as part of our treatment. And what I'm saying is that my patients don't have side effects. And if they do, we change things up to mitigate that. And I ask every single patient that I see in my day-to-day office hours, do you have side effects? And I will tell you, no. Oh, why are you asking me that? Should I? No. Or are there side effects? Or munchies? Okay, well, that is not liver damage that's going to lead to a liver transplant, right? So I think we have to really, we're fighting that propaganda, Conor, and I appreciate that you have this podcast and you share things with people. It's all about education, and I hate to say it, undoing the propaganda. I am one of the most, when I say conservative, like my husband, and I've told lots of people this, so forgive me if you've heard me say this before, but my husband says that I'm a chicken in a mommy suit. If you unzip, there's a chicken inside. I'm afraid. I worked emergency medicine. I'm afraid of everything, I've seen it all. And if I'm not afraid of this, I tell people, how did I become unafraid? Well, I educated myself and I talked to people who use it medically.
So when it comes to the endocannabinoid system, then with this, very obviously established physiological system, like the medical community wouldn't be able to refuse its existence. Why is there still then, do you think, hesitation about applying it through education?
The idea that, well, first of all, most medical schools aren't teaching about the endocannabinoid system. So most people graduate, become full-fledged clinicians, and haven't even heard of it. Or if they have heard of it, they've only heard of it and they don't know anything about it. But this is the reason why I'm convinced, is that if you were to diagnose somebody with an underlying endocannabinoid system imbalance or dysregulation, what is the treatment? That treatment is still on what we call the Schedule 1 Controlled Substance Act here in the United States. Many countries have similar programs where cannabis is highly, highly illegal. And what doctor is going to say, oh, you must have an endocannabinoid system problem. I'm going to recommend a Schedule 1 drug without having some real, true understanding of medical cannabis, which they don't get as part of their education. Everything I've learned, I've had to seek out on my own, just like you and just like others. I had to read the studies. I had to talk to patients. I had to practice medicine and get that feedback to understand this medicine. It is a specialty in and of itself. If you were to ask me what would then, like, how do we fix the quagmire that we're in with the medical community still denying this, or maybe saying there's something to it, but I don't know what to do. You need to go back for some continuing education, at least to understand two things. One is who might benefit. That patient with chronic pain who's escalating their opioid dose, and you really don't want them to escalate their opioid dose, and you've tried some other chronic pain type modalities and it's just not the answer. Do you just leave that patient there? I mean, to me, that's cruel that person needs help. This is just another tool in the toolbox. And then the second part is when somebody asks you about it. So yes, you can identify, but also if somebody asks you, you should have some ability to say, we have this underlying system. You appear to have maybe an imbalance in that system, and I think you should try cannabis. And then I don't really understand all of that, which is okay to say to a patient. And in fact, I think they would respect you more to say, I think you should pursue this. Patients don't want to lie to their doctors, but there's studies that show, especially older patients, they don't want to tell their doctors they use cannabis because they don't want their doctors to think they're a stoner. I mean, that's actually in the scientific literature. So a few years ago, I kind of got fed up with all of the lack of education within the medical community. It was triggered by a statement that a parent said, which really bothered me. At one point, I had a really long waiting list for children. I'm only one person. I can only do so much. The parent finally got in to see me, and the child's doing very well. But she said, we waited 2 years, and during those 2 years, my child had countless seizures. Why should we have to wait 2 years to see a doctor for this? And that really bothered me because that's a child's life. So I had decided, you know what? I'm just going to make an educational program, and I'm just going to make it free. Just put it out there. Because what is stopping people from learning about this? Is it the cost? Is it that they have no reliable source? I feel like I'm reliable 18 years now doing this. I've seen a lot. I wouldn't say I'd see it all. We still see new things every day, but let me just make this. And I met a gentleman who said that my book helped him tremendously with his cannabis use, stopped drinking alcohol. It has just totally helped him with all of his anxiety and all of the things he was dealing with, helped his mother with her dementia, helped his sister who had some other medical conditions. And he said, your book was life transforming for my family. I'd love to work with you. I'm interested in cannabis. And it turns out that he lives 3 miles from me, which is, I think, a message from the universe that we were supposed to work together. Anyway, we created Goldstein Wellness together. And what it is it's a platform for clinicians right now, just in the United States, but I'm hoping to expand it. But for any licensed healthcare practitioner in the United States, so an MD, a DO, a chiropractor, acupuncturist, nurse practitioner, anybody who's licensed with the state can sign up, sign in, and there's 50 videos on every topic, a lot of stuff we've covered to educate. There's a free certificate course. There's monthly webinars. And then there's this wonderful dosing tool that we created that allows you to put in the patient's medications and their main condition. And then options pop up, like option 1 might be high dominant, like for inflammatory pain, high CBD, low THC, CBDA. And then it kind of goes through. And if you click on the option, it gives you the dosing, where to start, how to titrate up, what to look for, how to understand the feedback that the patient is giving you. And then tips. Remember this, it could be, but you may see biphasic effects, for instance, in children with autism. Sometimes they get more hyper at low doses of CBD because CBD can be overstimulating or alerting in low doses, more calming, sedating in high doses. If you don't warn families that when you start at low dose, there's some kids that are low dose responders. You can't just pick a high dose and go. You start with the low dose, but you warn them. If your child's more hyper and more overstimulated, let me know. That's an indication to go up on the dose because higher doses are calming, sedating. And I very rarely see sedation in kids with autism at higher doses. But what's interesting is that if you don't tell somebody that, and then you say, go up on the dose, they're gonna be like, what? Are you crazy? My kid's already bouncing off the walls. I'm not giving him more. But you have to educate so that they understand. I have lots of parents now who do things on their own. They understand cannabis medicine because they've been working with their child and they've been educated. Goldstein Wellness gives all that to the practitioner. We also have a medication checker so that you can, list the most troublesome medications that might have interactions. And then additionally, we have a forum where somebody can post a question and say, for instance, I'm treating this patient and this is their response. I'm not sure what to do next. And then I chime in to try to help mentor and support the clinical practice and also help that patient who I haven't been able to see, but that somebody else is taking responsibility for and get, more brains involved in the care. I'm really proud of it. We have a small marketplace on there for hemp products, and it's literally just to support the IT and the education and to help continue to just make it free for practitioners. But it has been interesting in that many practitioners, even if you hand it across, they're already busy with their specialty. They may not have an interest in this. And I understand that. So what very exciting part of my website is Goldstein Wellness is a patient can sign up and find practitioners that are knowledgeable that can help them. It's a practitioner side, and then there's the patient side. And the patients can also, if they choose to, can get discounts on anything that's been recommended by the practitioner. So I'm really proud of it. And we only launched like maybe 2 years ago. It takes time to build a business, but we're very excited about it because it seems to me that things are changing here in the United States. It may go to Schedule 3, as you know. And then I think hopefully the medical community will be more interested.
Hopefully for everybody involved. But that's phenomenal. That sounds really exciting. I wish it was over here. I wish it was the case over here. But I think we've pretty much covered everything I'd like to talk about, Dr. Goldstein. So before we go, what do you find most exciting about the role that you're in and how you see the future of cannabinoid medicine?
Oh, that's such a loaded question. As you mentioned earlier, you said something about, how do they deny the science or, I mean, the science is irrefutable at this point. The endocannabinoid system is involved in our survival, in our well-being, and to deny its existence is to the detriment of our patients. So I would hope that anybody listening to this would at least bother to read about it. There's studies all over PubMed, Google Scholar, whatever you want to use, all over the internet. I would say do not let the fear of chronic heavy THC use outcomes that you may see in the news because it's, exciting to say, oh, cannabis causes this. Do not equate that to medical use. You must separate true recreational and that may not be problematic, but also problematic use. Do not equate that with medical use. They are not the same thing. Do not lump them all. I think we all understand that there's patients using opioids responsibly and patients that are not. It's the same concept. But I think the future is we're going to discover and understand about the other compounds in this plant. We have a lot of work to catch up on there. What do these compounds do? What don't they do? What are the indications for them? And then a way to measure success objectively. And that's why I got involved with the biomarker research or the salivary biomarker research, because that gives us a tool to be able to use in the clinic to document the benefits, to be able to see which compounds affect which pathways in the brain. When people don't do well, Conor, with cannabis, the big question is why? And I think one of the reasons is because these compounds are what we call very promiscuous. They have multiple targets, non-selective. And for some people, that doesn't work. They need it to be a little bit more narrow. I have a patient who's very, very, very complicated. I can't even go into the diagnosis, but it is like this long. Young man who's 25 now. He does not respond to, has a little bit of THC, but he did terribly on CBD, CBG. He does very well on CBDA and THCA, raw cannabinoids. Why? I think because they have a much narrow target list compared to CBD that is over 75 or many, many more targets, right? And so it just would be nice to have the tools to personalize, individualize in a quicker manner than trial and error. And I think that's where the biomarkers, the salivary biomarker test is very exciting because it also tells you exactly what's happening in that person, not their genetics, but what is happening in that person at the moment. And then I think also on the side of what would I like to see is cancer research. We're still losing a lot of people to cancer. We know cannabinoids have a role here. Let's figure it out. Let's get all of those studies really need to be done.
It's frustrating actually because we've not even really touched about cannabis and cancer, quite honestly, but the notion of when people say cannabis did nothing for cancer, and then you've got apoptosis, and then the numerous people that have taken it, they've cultivated cannabis themselves, they've used oil, and then it's removed their issue. That doesn't obviously happen for everybody, but there's certainly enough evidence and information to present a serious question when it comes to it.
And to pursue research, absolutely. And I don't see any reason why we wouldn't be able to do that. Uh, unfortunately, in my life, I have some loved ones with stage 4 cancer. They're going into clinical trials, or they're, like what I would call Hail Mary chemotherapy. And even the doctor says, well, I don't know if this is going to work, but we're going to try it. I mean, to me, I think people would be very interested in being part of research on cannabis to see if it would help them. We have a couple of studies that show that cannabis treatment at end of life may actually prolong survival. And of course, nobody wants to prolong somebody's pain and difficulties. But if someone is actually feeling okay and you can get extra time with your family and make memories, and especially with pediatric cancer, spend more time with your child before they're taken from you, to me, it's a worthwhile endeavor. Why should we not be studying this? And the whole idea behind, and look, we also know there's a lot of money behind the anti-cannabis movement because there are companies that make a lot of money off these patients and don't want you to find the cure. And I won't get into all that, but it's sad for humanity that here we are in 2026 and we still don't know which cannabinoids treat which cancers, how much should you take? Do you take it with the chemo and radiation, or should you take it separately? Should you alternate? I've seen that in the literature. Do your chemo first and then take your cannabis after. Some people take it together. I mean, we don't know. We have all these tools. Think about an electron microscope. Think about all the tests you can get in a hospital, right? This should be something that should be a priority for us as a people, right? As humans here on Earth.
Well, fingers crossed that in the future, the very near future, that will be the case. But yeah, Dr. Goldstein, this has been an absolute pleasure. Is there anything you would like to add before we go?
People can find me on Instagram. I've been trying to educate on Instagram as best you can on that platform. So it's Bonni, Bonni, and then Goldstein, MD. So feel free to follow me. I have my book out, Cannabis is Medicine, which is available. And it's a little bit dated, but it still gives all the basics. The basics of the endocannabinoid system haven't changed. The basics of the plant hasn't changed. And certainly, if you are suffering, cannabis may be the answer. And I know that our governments make it a challenge, but there are people who can help you. And you should seek them out and just see if it's right for you and do it the right way. Get some medical guidance or some supervision from somebody who actually has spent some time understanding this to try to limit side effects. Absolutely. Talking to someone ahead of time helps mitigate unwanted side effects as you introduce cannabis to your life. And so it is not a dangerous bad thing. It actually is the opposite.
Excellent. Thank you very much, Dr. Goldstein. This has been brilliant. Thank you so much.
It's really my pleasure, Connor. And thank you for being flexible with your time.
This has been very much worth it. So I'll make sure all the links are in the description box below. And if it's not this Thursday that the podcast will be uploaded, it'll be the following Thursday. But I'll drop you a link once it's good to go.
That's great. Thank you so much. And thank you for what you do and for educating people and putting this out there. It's really important work. So thank you.
Thank you. I really appreciate that. Honestly, that means a lot. Thank
And
you.
me
Well,
too.
enjoy your day. Yeah, good to meet you too. Bye bye.